Perfect. Hey, guys. Good afternoon. We got Brian.
Yeah.
Perfect. And Dr. Amin again from UW. So we're going to show placement of percutaneous fenestrated screws with cement augmentation. While we were in the last lecture, we started prepping. Again, we're using the same cadaver, so it is an open cadaver at this point, but we placed in the screws already. So these are essentially percutaneously built screws. So they do have your reduction towers on them. So this is the part that will stick out of the body, which will allow you to gradually pass your rods subfascially and reduce the rods to the screws once you're done with the cement placement. First thing we do is once we get our screws placed, we always get an AP and a lateral to make sure there's no obvious breaches, because you're going to have significant issues with cement extravasation if that happens. Once you're happy with your placement of your screws, then we can put on these cement towers. These will go in through the screws and lock into the tulips here. I believe we are making, awesome, great. And just to show you guys what the screws look like off on camera, can we zoom in right here, please? So at the distal tip, what you're going to see is a few of these fenestrations. Each company has their fenestrations at a different location, so it's important to be familiar with the company you're using. So what you'll see in this one, there's about 6 fenestrations to allow the cement to pass through, and then also you'll typically get some screw to come out from the tip as well. So what's important for placing these screws is that you really, really want to have these fenestrations pretty deep into the vertebral body, usually into like around anterior 1/3 of that vertebral body, to prevent that cement extravasating posteriorly towards the posterior vertebral body wall or the pedicles. Similarly, it's about Goldilocks maneuver, where you don't want to go too deep. If you do have a bicortical purchase of your screws, which is usually preferred for a non-cemented screw, but it will be causing an issue where you can get extravasation of these cement anteriorly and into the perivertebral body vessels, and so there is a risk for cement extravasation causing either pulmonary event or cardiac event. So typically you're advancing the cement here with lots of fluoroscopy, either live or I'll do single shot after each small amount. So are we getting them solidified yet? Perfectly. So while we're waiting for that to harden, again, follow your manufacturer. This one takes about 3 minutes to harden to get to a point where you're okay to use it. But what you'll do often is that time can be different depending on the temperature of the room, how often you're holding it. So if you're holding and manipulating the cement, it's going to get warmer faster. It's going to get warmer, it's going to harden faster. So typically, you're just going by the texture here. This one's very, very droopy right now, so very liquidy, so that's a high risk for extravasation. And what you're really looking for is something around toothpaste consistency. And often once you get to that toothpaste consistency, I'm trying to see if there's a lot of liquidy webs when I pinch my fingers together with that. If it's still too webby or liquidy, then you would want to wait. And so while this one is very liquidy and we're waiting for the rest to solidify, I will just inject one on camera here if we want to zoom back in just to see what this will look like when it comes out. We can again, let's see if we get that centered here. So again, this should be very liquidy here, just to give you an idea that you're going to get a ball of cement around your screw. And this is essentially not meant to substitute as a vertebroplasty or kyphoplasty. It's really just to improve your pull-out strength of your screw. So this should give about 200% extra pull-out strength. And the idea here is, with these patients with poor bone disease who are going to get radiation and who are very frail, we're really not expecting significant ability to fuse. So essentially what we're doing is stabilizing that tumor segment or the pathological fracture, and really depending on just fracture stabilization and depending on that cement to prevent pull-out here. Do you think we're getting to a point where you want to?
It's getting closer.
Perfect. And so we can at least start this part here. Sure, I'll do one and he'll do one.
Okay.
Again, another principle is we usually do this in lateral fluoroscopy and check with the AP. And then you never want to do at the same level, both left and right at the same time. So if you have, in that scenario, if there is extravasation, you're not going to know which side it's coming from. And so typically what we'll do in my practice is we'll cement all the levels on one side and then move on to the next one. So I think at this way we can both cement these at the same time, that way minimizing some fluoroscopy here. Now in this one with Globus, this is about 1.5 cc's of cement per filler, and that's usually the recommended amount, so 1 filler per screw. And then they have these little marks here for half, and the other half. So we'll go down to the first black line here. At this point, that's just getting cement all the way introduced through the tower into the screw, so you usually won't see anything on the x-ray. Can we get a C-arm x-ray there? Perfect, yeah, nothing there yet. And we may have some extravasation because we've used this cadaver and cannulated this pedicle quite a bit already with the previous demonstration. So let's go to somewhere around halfway of where the black mark is now. Okay. And I am getting some resistance now.
So as I said before, you do have a proprioception there, is that right?
Yeah, you can get a sense of the feel of it and how thick it is.
Hey, do you tell the anesthesiologist to do something special? So as an orthopedic surgeon, when we used to do cemented total hips, we'd always tell the anesthesiologist, give them some hypertension, iatrogenic, elevated naps, watch for DSATs, run the IVs wide open. We were worried about basic temporary hypertension.
Exactly what you're saying. Basically, as soon as we're happy with the x-rays and we're starting to make our cement, I let anesthesia know that we're giving this cement process, and then we start and then they're sort of monitoring the heart rate, the blood pressure, the pulse ox. They'll let us know if there's any issues here. And today we're having some significant resistance, which could be just the cadaver bone is very sclerotic. So we may not see a great cement fill here. Can we get a shot? Yeah, very trace amount there. We're getting a lot of resistance. I'm seeing a little bit up top, so I'll try to push a little bit more. And do we happen to have a mallet, guys, just for demonstration purposes?
Right there next to you.
Oh, perfect. So let's see if this will go. Let's see. And then can we get a shot again? Yeah. So very little flow from today's one, but I think we're just having an issue with the cold body here. There's a lot of resistance here. But typically from our studies, we're using this on most patients with cancer at this point. And what we're seeing is hardware failure rate with using this, very, very low, probably less than 3 to 4%. And again, this is because we're expecting patients using this on patients with a lower survival time. So essentially, we're not really seeing those hardware failures that we typically would in our DGen population because the patients aren't surviving long enough to get them. So this is really good for those palliative cases where we're trying to get the patient in and off the table. Other than that, in terms of the risk of like pulmonary embolism and all that, again, you're doing this under live fluoro usually, so you'll be very careful to look out for where the tip of that screw is to make sure there's no anterior breach. And then as soon as you start seeing the cement going towards the posterior 1/3 of the vertebral body, that's where I start slowing down how much I'm giving, taking more frequent x-rays, and really all we're looking for is about 1 filler is what's recommended just to increase that pull-out strength there.
What's the percentage pull-out strength that you gain from this?
So I couldn't hear you.
How much pull-out strength do you get?
So you get about 200% extra pull-out strength for each screw with that you've cemented.
Okay. And another question, and that is removal of one of those. So if you have to take a screw out that's been cemented, have you had that before, and what do you do? What are tips and tricks?
Yeah. So now when you get the increased pull-out strength, we're really talking about literally how the screw will pull this way out of the body. For example, if you have like a PJK and the windshield wiper issue. So in cases of revision, typically you can put a T-handle on your screwdriver and twist it out of the cement. You'll hear a visible crack and you'll feel it, and that's when you know that it's broken loose from that the cement ball around it, and then you can really come out with it. And so then if we are going to replace the screw through that same tract, I typically do drill through that cement. and then you're able to put a screw in, and you'll feel the difference. So when you upsize your screw for the revision case, you'll feel, just like when you do upsize in a regular degen case, you'll feel the pedicle, and then similarly, you'll feel that you're getting purchase of the cement that's there.
And a logical question just in the chat room. When do you decide to use this? Do you use Hounsfield units or something to help you make an informed decision as to when to use it, how to use it?
Yeah, so I'm using cement in most metastatic cancer cases where I'm not expecting good fusion on the patients, and where I'm expecting the patient to subsequently get post-operative radiation. So it's a lot for the bone quality here. There's limited bone quality because of the metastatic disease. Then they're going to get radiation. So I'm very concerned about the bone quality at the adjacent levels to the tumor. And so we're basically giving it to prevent pullout, and as well as because we're not expecting much fusion there.
Great. That came out well. Shall we look at an AP to see how that filled?
Yeah, I don't think we got much, but we can try. Yeah, it was really shooting out with the resistance.
Yeah.
Sure.
Brian has to work on his hand strength.
Sure. You guys want to take a quick AP, but based off of that lateral, we didn't see much coming out there. It was really getting stuck in the drivers.
I'm going to show your case.
What is it?
Metastatic lung.
What was it?
Patient was found down 83 on his arm. More? Yeah. Just, fusion and cement.
You have to move the serum over. Yes,
Yeah,
not
so you
much
can see
fill.
in this top one, there's a small cement cloud. Let's go a little bit center. Yeah, so right there on the top one, we're seeing a very small amount of cement cloud there, but that was less than the full filler. We were getting a lot of resistance in this cadaver bone today. And
Hate to tell you, I said so, but I still don't use cannulated screws. They're too expensive for me. I pre-fill the screw track, put cement down 1.5 cc's, and then put a screw in.
Yep.
I appreciate this lab, and I know that this has become very much a standard of care. I'm just a reactionary old guy, so disregard my comment. It was nicely done, though. Thank you so much.
Perfect. Thanks, guys.
So we have 3 cases to have.